I'm real excited for our next presenter, Dr. Del Rosario. He is a clinician at our 1401 North Palm Canyon Clinic. And he'll be discussing diabetes and insulin resistance in people with HIV. So a warm welcome for Dr. Del Rosario.
It's my job to keep you awake after all that good food, okay? It's sort of a lengthy topic here. HIV, lipodystrophy, and metabolic syndrome is one of the things that we as clinicians are treating a lot. And what I'm going to do at the end is a concept of these what are called Adepokines or fat hormones, which have been fairly recently discovered, as to think of as a new way to understand metabolic syndrome. So no relevant financial disclosures. Dr. Rodriguez's slide about showing the way the death rates have improved, we are going past the problems with early HIV, and now we're living with long-term HIV, and what that means as far as our HIV positive patients. None of our patients anymore who are on antiretroviral therapy are having to deal with opportunistic infections. And in fact, when I have the residents rotate through the clinic, we have to describe to them what PCP pneumonia is like, because none of them have ever seen a case of PCP pneumonia anymore. Whereas when I was in my residency program, that was primarily what we're seeing way back in the 1990s. So we don't have patients who suffer from immune problems anymore. But 40 years later now, we're dealing with the long-term consequences of the HIV medications. And what we see is this fat redistribution syndrome, which we've termed lipodystrophy. We're seeing problems with insulin insensitivity and abnormal glucose readings. So we're having to manage our patients with that. We're seeing lipid abnormalities, and as we've alluded to, and as Dr. Greenspan mentioned, we're seeing much more problems with cardiovascular issues with our HIV positive patients because of these lipid abnormalities, and more problems with heart disease. So these are all the things that we're needing to manage on a daily basis. And this is what we're dealing with, what we call metabolic syndrome in HIV negative patients. HIV positive patients have a type of metabolic syndrome, and we're going to talk a little bit about the differences here. On the first line there, in metabolic syndrome in HIV negative patients, they mostly have increased subcutaneous fat, whereas in our HIV positive patients, they have a fat maldistribution syndrome. Our patients with their abdominal fat, it's visceral fat, it's deep intravisceral fat, it's not necessarily subcutaneous. They also have a combination of a loss of subcutaneous fat peripherally from some of the earlier HIV medications, which we now no longer use because they were so toxic. And they also have fat accumulating at other places, which you wouldn't see in the normal metabolic syndrome, like the cervical dorsal fat pad. So there's some abnormal fat accumulations. Although high blood pressure is a definite part of metabolic syndrome in HIV negative patients, it's not necessarily a standard part of the syndrome in HIV positive patients, although it is very common that our patients are on antihypertensive medications. The things that definitely overlap are the glucose abnormalities, the triglyceride abnormalities, and the lipid abnormalities. So we usually approach these all differently in the treatment. So as far as therapeutic options, one of the things for lipodystrophy, which we try and do, is we try and alter their medication regimen. Unfortunately, we have fewer nucleoside backbones now to use. Before, we used to have a lot of nucleoside backbones up there in red. Now we don't use them anymore because for AZT, it's too toxic, too much anemia, the other D drugs, DDI, DDC, too much neuropathy, sometimes pancreatitis, other things. And now our other go-to drug, abacavir, which we used to use for people who had kidney problems on tenofovir, we now no longer use because of the results from the MACE study from the REPRIEVE trial, which showed abacavir has a significant risk factor for heart disease now. So we're down to only basically lamivudine, emtricitabine, and tenofovir. It looks like 4, but that's actually only 2 because emtricitabine and lamivudine are basically the same drug. They have the same mutation pattern, and it's just basically just tenofovir, the newer or the older form. So we have fewer options to change people to. We tell people diet and exercise, but that really doesn't do all that much to reduce the fat. It basically tries to help prevent further accumulation, and even that is not very effective. We have one medical therapy to treat intra-abdominal fat called tesamorelin, which is growth hormone releasing hormone. If that were the magic pill, we wouldn't be having this talk because it's not all that effective and it's expensive. So it doesn't really do the job as far as getting rid of the intra-abdominal fat. Surgery, there's no surgery for the intra-abdominal fat because there's no liposuction you can do it because it's deep beneath the visceral layer. Surgery only really works for the cervical dorsal fat pad. And that actually is a very special type of liposuction because it's a very fibrous fat. If you've actually seen it done, they have to use a grinding liposuction catheter to get rid of the fibrous fat because it's a very fibrous type of fat. So we have very limited therapeutic options as far as the lipodystrophy. For the treatment of cardiovascular risk, all the internists here and the family practice doctors and nurse practitioners, we're familiar with using all the regular cardiovascular medications. The ones there in blue are the ones we commonly use. In our male patient population, unfortunately, they don't like the beta blockers because most of our positive patients are male in my practice, causes problems with the erectile dysfunction, so they never want to take their blood pressure medications that way. We use the ACE inhibitors and angiotensin receptor blockers, but we have to be careful because the primary nucleoside backbone that they're on is now tenofovir. So we have to worry about the drug interactions, problems with our kidney function to begin with because of their HIV medications. Some underutilized ones, minoxidil. I find my patients really like that in the practice because it helps them with their hair loss and it makes them furrier. And a lot of my patients like being furrier. So that's one of the reasons that they will actually take their minoxidil blood pressure medication where they won't take their beta blockers. As far as the treatment for hyperlipidemia, we are standard using statin therapies. And again, Dr. Greenspoon's lecture this morning really drove home the point that statins are now really indicated for HIV positive patients if their pre-treatment risk factors are above 5%. Ezetimibe, we also use that. It basically inhibits cholesterol absorption in the stomach. Bempoic acid is a relatively newer medication that also inhibits cholesterol synthesis at a different place from the statins, which are HMG-CoA reductase inhibitors. And then lastly, we have the PCSK9 inhibitors, a newer class of medications, mostly reserved for people who are statin intolerant, but they also do, they serve a function of as far as really reducing the LDL cholesterol. So again, we're approaching these sort of all for different reasons. We're treating each aspect of a metabolic syndrome a little differently. As far as the glucose abnormalities, which I think we're going to focus on today, very commonly we use the bigronides, which is only one of the classes of metformin. It's first-line treatment, limited, unfortunately, by GI intolerance for some people. Most about 60–70% of people are perfectly fine on metformin, but about 30% cannot tolerate it due to GI problems. Sulfonylureas are probably underutilized in HIV. The only problem that we worry about in clinical practice is it can cause hypoglycemia if those people aren't eating throughout the day. There was a lot of talk about the thiazolidinediones like pioglitazone and rosiglitazone for thinking that it may actually help improve intra-abdominal lipid accumulation, but the studies really haven't panned out with that, and some studies have actually shown that it may increase intravisceral fat. But the big thing is pioglitazone has been associated with congestive heart failure, which now limits the use of that medication. The other ones, the DPP-4 agonists like sitagliptin, saxagliptin, Januvia is the brand name for one of those. That helps block the GLP-1, helps result in better insulin sensitivity. These are also fairly well-used medications. Unfortunately, they're expensive, so we have a big Medicare population here, and it makes it more difficult for that to get covered for our patients. They also help reduce markers of inflammation. And again, from Dr. Greenspoon's lecture, we know how important reducing inflammation is for the overall treatment of cardiovascular risk factors in HIV positive patients. So the DPP-4 agonists help reduce these inflammatory markers. And again, Dr. Greenspoon mentioned high sensitivity C-reactive protein is probably one of the markers we're going to be tracking soon. The big news that everyone knows about now are the GLP-1 agonists. Basically, this is Ozempic and Wegovy, Zepbound, and Mounjaro. They're the ones that are making all the news. They basically work by slowing the digestion, and people feel more satiety, and they stop eating. So this is actually probably the only weight loss medication I actually prescribe because it actually does work. But we sometimes forget that it helps improve insulin sensitivity, it reduces hepatic gluconeogenesis, so it works on some of the mechanisms that we want to do and improve glucose intolerance. It did show that this actually does work in HIV positive patients and patients with HIV. They used it in the clinic. They were using semaglutide at only 1 milligram, so they didn't actually use the maximum dose of semaglutide, but it showed that it actually does work. It also showed that semaglutide in addition to the DPP-4 agonist, also help decrease inflammatory markers. So these are some of the inflammatory markers. Again, C-reactive protein is there indicated. And it also shows that the weight reduction works best in the people who are the heaviest. So the people who are in the lowest normal body weight, not much weight loss, but people who are in class 3 obesity had more weight loss. So it actually works where it needs to work. And again, this was also this was proven in HIV positive patients. And it did show that we have actually one study that showed that it actually did reduce intravisceral fat in HIV positive patients. So people with lipoaccumulation who have the sort of hard belly that the patients refer to. It actually did show in this relatively small trial. Again, they used only the 1 milligram dose of semaglutide, which is not even the maximum dose, but they showed about a 30% reduction in visceral fat. So not overwhelming, and certainly in clinical practice, I've used this a lot with our patients who have both diabetes and intravisceral fat accumulation. It doesn't give them their flat ripped abs back. It reduces the fat somewhat. They still have a bit of a belly there, but there is some improvement. Again, 30% it's okay. We wish it was more, but there's now a proven reduction. And it also showed that there was a significant weight reduction. Some patients have noted that there might be some decrease in lean muscle mass. They did see that, but the vast majority of the patients in this study did not really exercise. They just used the GLP-1 agonist for the weight loss. So we don't know if encouraging our patients to exercise more would help overcome this loss of lean muscle mass, but it was not a significant amount in this modest use of semaglutide. And then the thing I wanted to talk about is actually what are called fat hormones or Adepokines as a way to understand the metabolic syndrome, because it seems like there's cardiovascular issues, there's blood pressure issues, there's fat redistribution issues, there's diabetes, there's hypertension, there's all these things which don't seem to be all related. But these recently discovered fat hormones may have give us a different framework of understanding them. So Adepokines are basically signaling hormones that are secreted mostly from fat tissue. They were initially discovered in adipose tissue that help regulate metabolism. And these are some example of some Adepokines. Leptin was the first one that was discovered. You can basically think of this as an enzyme or hormone that regulates how much fat you have on your body. So when you have a normal amount of fat, your leptin levels are normal. When you are in starvation mode, your leptin levels decrease, and it triggers behaviors which will help replace your fat. So that's one of the things that leptin does. Resistin, probably not much use for us clinically because it is a pro-inflammatory cytokine that causes inflammation. And again, we know from Dr. Greenspan's lecture that inflammation is a big deal when it comes to HIV, both with glucose intolerance and our increased risk factors for heart disease. So how these hormones fit in with inflammation is an important part. Visfatin is basically a hormone that's released mostly by visceral fat. And again, it helps regulate the production, what it does, it helps with, it's an insulin mimetic agent that helps govern the action of insulin on visceral fat. The one we're going to talk about mostly, though, is adiponectin, which is a hormone that helps regulate normal metabolism. And when its levels go low, it helps explain some of the things that we're seeing for metabolic syndrome. So I'm just going to talk very quickly about leptin. It was the first adepokine discovered in 1994, so these are relatively recent molecules. It affects pathways for energy homeostasis, and normal leptin levels in the body signify that you have enough fat on the body, enough energy storage. When you have a decreased leptin level, that signifies that you're in a more starvation state, and that triggers all sorts of things that help you restore your energy state. So when you have a low leptin level, your appetite is increased, you want to eat more. It signals you to decrease energy expenditure. When you're starving, you don't want to expend too much energy. It actually affects behavior. It affects sexual behavior. It's been found to be effective, have receptors in the hypothalamic pituitary axis, because when you're starving, you don't want to be expending energy on sex. So you downregulate your pituitary hormones for testosterone and estrogen. And when you are starving, you're in a stress state, so you actually upregulate other pituitary hormones like cortisol, because that's your stress hormone during starvation. So there's some wide-ranging effects that these fat hormones have on both metabolism and actually behavior. And here, this is some data from some studies that showed what leptin levels are like in the different phenotypes of lipodystrophy. So if you have mostly lipoatrophy, where you've lost a lot of mostly peripheral fat, your leptin levels are low, because again, it mimics how much fat you have on the body. For people who have the hypertrophy model, the lipoaccumulation model, when they've got the big belly, their leptin levels are higher than normal. And when you have a mixed picture, they're arranged in between. So if people have both the lipoaccumulation in the abdomen and the peripheral fat loss, their leptin levels are somewhere in the middle. And people who don't have any apparent lipodystrophy symptoms, their leptin levels are normal. The one we're going to talk about, though, that most probably helps us explain the metabolic syndrome is something called adiponectin. This was discovered a year later after leptin in 1995. It's a small protein. It's secreted mostly in subcutaneous fat tissue. They found that it's secreted in other places too, but the vast majority of it is secreted in subcutaneous fat tissue. So it gives you an idea of whether or not you've got enough subcutaneous fat. They've also seen it in marrow, skeletal muscle, heart muscle, endothelial cells. So the distribution of this gives you an idea that how important it is for the picture of this metabolic syndrome, because it affects all sorts of different aspects of metabolic syndrome. It affects muscle metabolism, it affects heart, it affects your endothelial cells, and again, in that regard, your coronary arteries, like Dr. Greenspan showed, that as far as the inflammation levels in there. So it also promotes glucose metabolism, and it improves insulin sensitivity. So when your adipolectin levels go low, you have decreased insulin sensitivity and problems with hyperglycemia. And it also has an anti-inflammatory effect, again, relating to cardiovascular risk there. So this is what it looks like. It's a 244 amino acid. There are different forms of it. So that single 244 amino acid, 3 of them form together and form something called a low molecular weight adiponectin, or a trimer. When 2 trimers get together and form a hexamer, that's intermediate weight adiponectin. And then there's a high molecular weight adiponectin, which is about 12 or 18 trimers or monomers all stuck together. That makes a high molecular weight. And there's a globular form where you just cleave off part of that C1 esterase-like portion of there. That's a form of a globular. So the reason why this molecule has so many different acts is because there's different forms of it, and they bind to different receptors. And there's also a telling thing of how important this is. This hormone exists in micromilliliter doses. Most hormones exist in nanomillimeter or nanomicroliter or picomicroliter doses. So this is a very, very prevalent hormone. It may account for as much as 1% of the circulating protein in the body. And as they have different forms of the molecule itself, the fact that it's so pluripotent, it also has lots of receptors. It has 3 receptors. The primary receptor, AdepoR1, exists in skeletal muscle, and that's responsible for maintaining normal metabolism, fatty acid metabolism, how you metabolize your energy sources. AdepoR2 exists primarily in the liver, and that helps to manage gluconeogenesis and how we respond to maintaining normal blood sugar levels in the body. And again, some of the globular form versus the high molecular weight form have different binding affinities for these molecules. There's even a third receptor called cadherin, which exists mostly in the endothelium, and that is responsible for most of adiponectin's inflammatory or anti-inflammatory effects. In normal levels, it's anti-inflammatory. When the adiponectin levels go low, it becomes inflammatory and increases risk factors for inflammation and, as we've seen, heart disease. So what does low adiponectin levels do? When you see a low adiponectin level in patients, that you tend to see abdominal obesity, which is again part of the metabolic syndrome and the intra-abdominal fat accumulation we see in HIV positive patients. Patients tend to get hypertension. And again, this has to do with the endothelial effects of this molecule and inflammation. And you get abnormal glucose levels because a low adiponectin level causes you to be less sensitive to your body's own insulin, and you do less oxidative phosphorylation. And then it elevates your triglyceride levels because it stimulates, it wants you to retain more fat when you have adiponectin. Again, it acts counter to normal metabolism, and it lowers your HDL levels, and it can, in higher doses, cause diabetes. So all of this stuff is basically metabolic syndrome. So what we can use is adiponectin and these fat hormones to understand the various aspects of metabolic syndrome and how they can be different in HIV. So one of the roles which they found that adiponectin may plays in HIV in the metabolic syndrome and the lipodystrophy that we see is that, again, adiponectin is secreted primarily from subcutaneous fat. So when you have certain nucleosides like a stavudine, old Zerid or D4T, that was primarily associated with a loss of subcutaneous fat. So that then resulted in lower adiponectin levels. Protease inhibitors, in particular Norvir, were also shown to inhibit the normal angiogenesis of fat tissue in adipocytes, and therefore it inhibited normal fat differentiation and resulted in lower adiponectin levels. So both two classes of medications, the two most common ones which we used before, the nucleoside and then protease inhibitors, were both associated with a decreased adiponectin levels in the body and then resulted in these metabolic syndrome consequences. The other thing that adiponectin levels affect is cardiovascular risk. And again, we've seen that HIV positive patients have significant increase in cardiovascular risk. So low adiponectin levels strongly associate with ischemic heart disease and can actually independently predict risk factors for heart disease in people, regardless of other normal cardiovascular risk factors. And again, it's significantly predictive of cardiovascular risk factors in men. And then hypertensive patients also have lower adiponectin levels, and that was shown by several different studies here. So again, another part of the cardiovascular part of the metabolic syndrome, which can be explained by these fat hormones, which go low in HIV. And as far as diabetes, obesity reduces adiponectin levels, and obesity is a pro-inflammatory state. So when you are overweight, your adiponectin levels can go low. HIV results, and again, the nucleoside stavudine and the protease inhibitors also result in low adiponectin levels. It leads to a pro-inflammatory state of those CRP, tumor necrosis factor alpha, and IL-6. Those are some of the cytokines that also go up as a result of low adiponectin levels. And again, this helps, it forms us of cardiovascular risk as far as the increased levels of inflammation. And so this is just a sketch of the adiponectin levels effects on the body. It has a protective effect there on the pancreas by promoting beta cell function. When you have decreased adiponectin levels, you get into more of an inflammatory state. Those inflammatory states result to insulin resistance. And again, the adiponectin R1 or 2 receptor in the liver, when the adiponectin levels are normal, it decreases gluconeogenesis, it decreases lipid content, it promotes fatty acid oxidation in the skeletal muscle on the R1 receptor. And again, the fact that it has anti-inflammatory effects helps improve insulin resistance, and it helps promote normal metabolism in fat. So that's one of the things that we're going to be looking for is adiponectin analogs that are going to, if we're going to restore adiponectin, do we make things better? So in where we talked about the metabolic syndrome, we have problems with different fat accumulation. We have fat redistribution, we have glucose abnormalities, we have triglyceride abnormalities, and lipid abnormalities, all of which we were treating with different medications, statins, anti-diabetes medications, sometimes surgery, dietary modification, things like that. But all of them are touched by adiponectin in these fat hormones. So these are just some examples of some of the uses that we may be seeing in the future for them. Adeporon and an experimental medication, ADP35, are adiponectin receptor analogs, and they're now being taken a look at for the use for improvement of fatty liver disease in patients. Also, they're being used to take a look at the response to diabetes in a diabetes model in humanized mice. So these are still relatively early, but these are some of the things that we're going to be looking for in the future. For the most part, the pharmaceutical industry is probably going to aim this more towards metabolic syndrome, but as we've seen, some of the adiponectin problems when you have a decreased adiponectin also mimic the HIV lipodystrophy syndrome that we see in our HIV positive patients. So these are probably going to be also used in the treatment for lipodystrophy. I know that was quick because we had to go through this. But if there's any questions, that was it.